We're now going to move on to Jerry Scott for his keynote presentation on communication, collaboration, and leadership in healthcare security. Before I introduce Jerry, if you have a question for Jerry, you can record it at any time. We'll save Q&A for the end of this presentation. Jerry Scott is the current Chief Protective Services Officer at Alberta Health Services, with responsibility for safety and security of Canada's largest healthcare organization. He oversees a service which includes close to 1,000 frontline staff supported by a full-time provincial security communications center, a corporate investigations unit, and an accredited training and development program, fire and life safety team, and an enterprise security systems program. Before joining Alberta Health Services in 2018, Jerry served for 28 years, more than 28 years in the RCMP in several Canadian provinces. Jerry Scott holds a bachelor's degree in commerce from Dalhousie, 2 executive development certificates from the University of Alberta, and he is a certified healthcare protection administrator. Please welcome Jerry.
Thanks, Neil. I want to start off by thanking you for allowing me to come here today and speak to everybody. As Paul had indicated, the last 21 months has really changed the way we operate on a lot of the things we do on a day-to-day basis. Certainly for me, the virtual world is not something that I'm overly familiar with or comfortable with prior to the pandemic. I'm more an in-person, want to shake your hand and those type of things. But I will go over fairly quickly today my organization's background, what our protective services program offers, some current trends that we've seen throughout the pandemic, and how collaboration and interoperability has been key to trying to keep the lid on things during these very trying times. And then I'll talk a little bit about some future challenges for healthcare security going forward and take a few questions. So as you indicated, Neil, we are the largest fully integrated healthcare system in Canada, and it was launched by direction of the provincial government in April of 2009. So we're a province of 4.4 million people, and we have a demographics that is one of the youngest within Canada. And that comes into effect later on when we start talking about the crime severity index for Alberta and just the type of violence that makes its way into our facilities. We have, a young age, average age around 38 years old. We were big in oil and gas. We're still big in oil and gas. And so we work hard and we play hard out here in Alberta. So, and that is definitely represented to when we look at societal discord coming into our facilities. We have approximately on any given day about 109,000 direct employees. I thought when I worked for the RCMP, who has about 30,000 nationally, that was a big machine. This one is something like I've never experienced before. We've got a total of almost 11,000 physicians. Most of those are contracted in support of AHS. They're not employees of AHS, and that can become challenging for us sometimes when it comes to their safety and when we do investigations in support of the College of Physicians and Surgeons or our medical affairs teams. And we wouldn't be anywhere without our 12,000 plus volunteers who devote their time to the care of our patients and staff. So just overall, again, on the left, you'll see the new South Health campus out of Calgary. It is a massive facility. I forget the last time we did a measurement of everything that's in there because there's still the ability to build on there, but it is massive. And then on the right is the University of Alberta Hospital in Edmonton. We have responsibility for about 900 facilities. We do contract out some of those, but overall, if something happens in one of those 900 facilities, it'll usually land on my desk or one of my teams. So Primarily, we have 106 acute care hospitals. We have 5 dedicated psychiatric facilities and about 40,000 beds that are in service. And this is just a way of a breakdown, because as I start to go on about the pandemic, you'll see there's a significant number of spaces in continuing care, long-term care, and designated supported living. And that became a real challenge for us during the pandemic, when isolation and lockdown and the care and protection of our most vulnerable members of society, the elderly, really hit home for us. So what is protective services at Alberta Health Services? We are broken down into 3 levels of a hybrid system when it comes to frontline people. We have community peace officers, we have contracted security guards. Paladin is our sole provider currently. And Paul talked about, labor shortages and challenges to try and recruit and retain people in the healthcare field in the middle of a pandemic. We initiated a safety ambassador program at the beginning of the pandemic out of necessity for capacity. And they are in plain clothes, golf shirts, dress pants, with the Protective Services logo. And they are a key component to our screening and access control, as well as early eyes onto issues of behavioral issues. Got a training and development unit. What's important here is that we are accredited by the Ministry of Justice in Alberta to train our peace officers. And we train not only our peace officers, but other peace officers within the province of Alberta. And that speaks to the professionalism, again, that Paul brought forward. We are recognized, we're recognized by our peers, and we're recognized by law enforcement as having a very professional service delivery. We have an overall communication center that manages calls for AHS in the province. We have a corporate investigations unit who became very active in threat assessments and risk assessments during the pandemic. Our enterprise security teams are really the technology for us when it comes to try and to protect infrastructure and individuals. And then we all have to have a fire and life safety program in order to not only to be compliant with the fire regulations, but also to be, work with our clinical partners to ensure they don't do things like lock and fire doors to prevent elopements and those type of things. So there's a lot of collaboration that goes on with my team in fire and life safety between the fire department, municipalities, occupational health and safety, and clinical folks. I've got a little bit over 600 full-time peace officers. We are second only to the Alberta sheriffs when it comes to numbers. And we also, if you ranked us with our law enforcement partners, after the Mounted Police, Calgary Police Service, Edmonton Police Service, and the sheriffs, we are next in numbers in pure size. And of course, we get our authorities from the Minister of Justice, and they're the normal authorities you would see within a healthcare environment. When we talk about our mantra and going forward, so Alberta Health Services is a patient-first organization. They provide patient and family-centered care, and so we're there to support that. And we have to be professional, and we have to have the engagement. If you don't have those two things, you'll never be successful. And that leads to the collaboration, whether it's internally or externally with your stakeholders. We've termed the saying, we're partners in care, because I think at times security in a hospital is looked at by some as the equivalent of mall security or construction security, and nothing could be farther from the truth. We want to prevent things, we don't want to respond. But as you will see in a little bit, when prevention doesn't work, you better have a critical and timely response model in order to prevent injuries. We do a lot of collaboration with our workplace health and safety teams, our addictions and mental health teams, and our law enforcement. We spend a lot of time dealing with issues with law enforcement. We've got an opioid crisis here in Alberta that other parts of Canada are experiencing. And, the pandemic has really brought on issues around addictions and mental health. So that's why we get that high level of accreditation for our officers. And we use that hybrid model for efficiencies, for fiscal responsibility. And what I think makes us unique a little bit is we have a rural mobile units, which are peace officers in vehicles that have a patrol area, similar to the RCMP. And that allows for us to respond to incidents in facilities where we don't have on-site security. So of the 106 acute care facilities, we have only 47% coverage, and that's not always full-time. So we do have a challenge in that regard. We respond to over 500,000 calls for service. That doesn't include the self-generated ones. Well, 40% of those originate in the emergency department, and 55% of those will have some connection to either a mental health concern or an addiction concern. Our communication center is busy, and they take on 40,000 plus calls a month and 150,000 radio transmissions. We have about 6,400 cameras that we have access to in our facilities. That is helpful to us, obviously, but it also creates issues in and around the Health Information Act and our privacy obligations. So I'll get into a little bit about the current trends, and I just note here that in 2020, we saw a real increase in violence within our facilities, which is a bit counterintuitive because we, for the first time ever, we locked them down and we controlled access a lot more stringently than we normally do. And so when we looked at the pandemic, and it's been going on for some time, our primary focus in March of 2020 was around facility access and controls. And those controls certainly are physical in nature, but they're also resource heavy in nature. And, I talked about the continuing care and long-term care facilities. There's about 176 facilities across the province. And I remember getting a call one night to ask if I could lock all those facilities down and put people, security people in them by the end of the week. To which I said, no, we're not set up for that. But we've definitely seen violence ebb and flow. The restrictions that the governments have placed and kind of the lockdowns and the openness and thing, we get caught in the middle of it. We get caught in the middle of it with our clinical teams who are doing their very best to deal with the healthcare issues of the pandemic, but also trying to navigate some of the social disorder and anxiety that came along with that pandemic. Paul mentioned, a labor shortage in the US around contracted security. We've seen that here in Alberta, so much so that it's really, I've had to go out and create additional capacity internally because we're able to hire and offer more of a career path, perhaps in healthcare security, for folks that makes it a little bit more attractive. We saw a real movement towards anti-government healthcare views. We've had protests across Canada at our facilities as the vaccine mandates came out. And that really shook a lot of psychological safety concerns for people within healthcare and our leadership. Public Health Act enforcement. So when I arrived in 2018, I had no idea the Public Health Act enforcement teams that were in AHS. And I slowly became aware of them as they started to face backlash within the community. We don't have authorities within the community outside of AHS facilities. So the public health inspectors that are out dealing with issues, they were starting to get threats. They were starting to be subject to social media harassment, intimidation, and such. And so we were brought in to try and offer guidance because they're employees of our organization. And we did some things. We locked down some churches that weren't complying with regulations. Needless to say, the communication folks were very busy. Our collaboration with law enforcement was key in doing so. I sit in a regular weekly meeting with the Deputy Minister of Justice and the Chiefs of Police in regards to Public Health Act enforcement and how the pandemic has really shifted some of the social discord here in the province. And so that translates all into the psychological safety and employee wellness piece. So it's just not the pressures of the pandemic that are thrust upon healthcare. It's the additional pieces of, well, we're normally supported by good public support, and all of a sudden we have a certain segment of society that's targeting our folks. And so that was a real focus for us. We put out a number of different bulletins in and around how to stay safe, how to deal with social media, how to structure your social media accounts, whether you should or shouldn't advertise your employment with Alberta Health Services. And then we build upon the employee wellness piece. So we have a private third-party provider that deals with EFAP, but we had to build internal mechanisms. So communication was key. We had regular meetings with my management team in and around employee wellness because most of our folks will work themselves right into the ground if you allow it. And so we had to formulate some strategies to ensure people got time away. Certainly, I think we're in the end of the fourth wave, potentially with Omicron going to get into a fifth wave, but we really had to focus in on that because our folks were working their tails off, and a lot of them were not taking good care of themselves. So this is just an activity log on some data. And what's kind of interesting here is that our incident reports between 2019 and 2020 only went up about 6%. And our activity logs, those things are kind of regularly structured, unlocking doors, morgue visits, wayfinding, just a lot of different normal day-to-day things. But when we went into the workplace violence, you'll see a significant increase in the number of incidents that took place. And so that should get anybody's attention within our organization, and it did. But what was interesting is that we kept our disabling injury rate due to violence steady in 2020. So despite the rise of almost 25% in violence, we were able to mitigate the severity of those injuries due to that violence to a point where we didn't have people lost time. And of course, lost time translates into money, as well as, you know, psychological safety, employee wellness, all those other kind of things. And so our COVID incidents, they ebbed and they flowed, depending on when the lockdowns were really heavy and when things opened up. And the local law enforcement saw a direct correlation in its levels of violence in society with that kind of roller coaster ride. I just throw this out here to let you know that we confiscated this off of one patient who presented in an emergency department seeking mental health care. This is typical for us on any given day. This is just one patient. There's about 17 edged weapons. There's a can of lighter fluid. There's 2 flasks of alcohol. And so, this individual was not in such a crisis that he presented a physical danger, other than the fact that he had access to all these weapons. And should he have chosen to act out, my teams would have been in tough. But we take the time through collaboration with our clinical staff and our EDs. We train a lot. We do simulations, we do all kinds of things. And so when we get an individual that presents like that, these things were secreted all throughout their clothing. And but they certainly were wanting to have enough arsenal on them to keep themselves safe in society. So I talked a little bit, and I'm not so sure if you can see the whole slide here, but this is where the collaboration comes into account. So we can't do anything by ourselves as a security team. And because of that partner in care kind of mandate, what we've pushed is we're part of the care team. So we get in on patient care huddles where there are behavioral issues. We form part of the steering committee for the prevention of harassment and violence work that's being done. And so you have two philosophies. You have the prevention of violence and you have the response. And people get it lost on them because they say, well, if you prevent violence, then you shouldn't, need such a robust response. If we can train our healthcare people in de-escalation techniques and communication strategies and risk mitigation, then we don't need that many security people because we'll just prevent these things before they ever occur. The challenge with that is when that doesn't work, and if you have a methamphetamine issue, so Edmonton, where I live, has the highest concentration of methamphetamine in the wastewater in Canada. Not something to be really proud of, but it kind of speaks to some of the issues we deal with. So violence prevention is key. It's a good investment. It saves money. It keeps people safe. But you also have to have a response when those prevention strategies don't work. And that's been a real interesting conversation to have with healthcare leaders when they're looking at the pressures economically. So just kind of broken down the two kind of different models, and so the collaboration, we're an organization, I think we're the 4th largest organization in Canada. When you try and get a culture change or institute a change management direction from making security everybody's issue as opposed to just the protective services issue, you really have to utilize all the tools available to you. And so this is just a slide that demonstrates on the left-hand side, those are the elements of a response model. There's no magic in there. Certainly code white training helps in our facilities where we don't have a presence. De-escalation is always a good idea. And then obviously, we do investigations and debriefings and all those other kind of things. But if you don't incorporate kind of well-being and resiliency, communication and that relationship building, that partner in care philosophy that we are all one team, and you really need to approach this together, you really are going to miss opportunities for success. Just another thing around, general precautions when we're looking at psychological safe work care environments, and then for the individuals to actually know these strategies. These are the 4 streams that we kind of chunk it out into. It's obviously prevention planning, the supports and the collaboration, that cultural piece to sustain what we're trying to do. And then we do a lot of learnings, a lot of training. We've trained over 30,000 healthcare workers in non-crisis violent intervention since I've been here. So what does the future hold for us going forward when we look at healthcare security? We've got a number of challenges. We've got a labor shortage that's out there. We've got climate change. And so climate change, how does that wind its way into healthcare security? Well, I can tell you that the plant that makes our ballistic vests in Louisiana was taken out in one of the latest hurricanes. And so that provider can no longer provide us with ballistic vests. We've tried to order jackets, our uniform jackets, and at last count, I think we're at an 11-month delay with our current supplier due to fabric issues out of Germany. COVID-19 and its variants. Omicron is the latest. We have it here in Alberta. I would suggest it's in every province in Canada and will be so in probably all the states in the US. And so as we move forward, as our teams, both healthcare and security, are 21, 22 months into this, and they've had those stressors, we're starting to see the operational stress injuries come forward. And so that has a kind of a dual effect. One, it's not good for your people, and it's not good for your ability to meet demands and capacity. And so focusing in on that, we've hired a project manager. We are going to include and develop our own peer support network within our protective services program. We are going to co-locate that with our ambulance service or our EMS. And we've had lots of conversations about not only early interventions, but the reintegration plans that go along with that. Vaccine mandates. So AHS has a policy of vaccine mandates. It will come into effect on December 13th. I am going to lose about 4% of my staff, which doesn't sound like a lot until you know that I have 1,000. So it can impact you. The economic impacts of the current world right now are going to bleed over to budgetary issues for all healthcare security teams. And so while your violence continues to rise, your leaders are going to be put under the gun to not spend. No secret, we have a pressure on healthcare, including nursing shortages. I read an article out of Ontario that says they're basically on the brink of collapse. Now, I don't know if that's true or if that's just media doing their media thing. But we have seen a loss of experience due to retirements, and our nurses in our emergency departments seem to get younger and more inexperienced on a daily basis. We still have a defund the police mentality, and recently in Edmonton, the police service lost some budget that was transferred over to another public facing entity. That makes its way into our healthcare facilities. And, you know, we're not seen as the police in Alberta, but we have a close connection to it. So, you know, when you see that happen to the second largest police service in Alberta, you better wake up and pay attention to it. I talked about the opioid crisis. We have aging infrastructure in our hospitals, and we have, like I say, 106 acute care, but they are in different states of ability for systems, physical security systems to talk to one another and those type of things. New technologies are great. They butt up against privacy and healthcare all the time. And I routinely get into conversations on things like body cameras, facial recognition, metal detectors, those type of things. The surgical backlogs and delayed diagnosis are only going to put more people in our facilities. It's not going to make it less. So we're looking at different opportunities about care in the community and those type of things, but it's still going to put pressure on our system. And then last but not least, we're going to see an increase in mental health issues, especially among young children. Isolation and the inability for people to connect is starting to see itself manifest in our children's hospitals. And it is a real worry for us going forward, just how much of an impact, because I don't think anybody really knows. So thank you very much for putting up with my PowerPoint presentation. I'm happy to take questions now if time allows. I'm also happy to take them through my email and connect with anybody who'd like to have further conversations. So appreciate your time. Thank you.
Thanks very much, Jerry. That was a great presentation. We have a couple of minutes for Q&A with Jerry. So if you do have a question for Jerry, now's the time. Sorry, Jerry, if you just want to keep your camera on for just a couple more minutes. I think it's more of a statement, but I'm going to read it, Jerry. Maybe you have a response. Thanks for bringing up the conflict between prevention and intervention. Everyone ignores the intervention part, and yet this is an area where we experience most injuries, and it is an opportunity for IAHSS to determine best practice. A common best practice of intervention could possibly prevent serious legal issues.
Yeah, I think it's an answer that certainly within law enforcement, I've seen the use of force issue come up routinely. We've seen it within our organization. We strive very hard to get that de-escalation in there in and all possible. And then if it's a intervention style, that's where your training and your professionalism comes in play, and you use as much as you need to, as quickly as you can, to get that situation under control. We had a use of force review done a couple of years ago by our legal team, and it was just something that wanted to see where we were at and just how many of these actually did, because you can get an urban myth that one incident, it's all over social media, and all of a sudden, the protective services team is clubbing patients or visitors. And what we saw is, I think 3% were actually founded. So I think, it speaks to the training, it speaks to the collaboration with clinical, who understand when we have to go hands-on, and that communication piece afterwards when we debrief about what happened.
Thanks, Jerry. I might ask you one more quick question. What advice do you have to help address stress management issues among security staff working in healthcare?
I would say, come at it head on, talk about it. I talk about it every meeting I'm in, between diversity and inclusion and operational stress management are my two kind of drums that I beat. I think you have to be courageous in knowing when to have those conversations with people and say, I see you heading down a path that isn't good. We're a big organization. We have a home with a good provider, but internally to our program, we need more. Our folks want to be able to talk to people who have been there on the front lines and have that experience. But I think if you put your head in the sand and choose to ignore it and just let your third party provider kind of try and pick up the pieces after the pieces crumble, you're in a lose-lose. So I would say examine what you have to offer and build something sooner rather than later. But don't be shy about talking about it, because I've lost in the past year 3 people to suicide, and that has a real impact on families and coworkers and things. And in this day and age, you're silly if you don't address it head on.
Thanks, Jerry. We appreciate you spending some time with us today. Thank you for that amazing presentation. Really appreciate your time.